Very excited to introduce our next speaker, Dr. Mike Twohig. Dr. Twohig is a professor in the Combined Clinical Counseling PhD specialization in the Department of Psychology at Utah State University. The focus of his research is to develop effective treatments for problems of social importance. Therefore, his clinical interests are quite wide and they're not topographically based on any one condition. He predominantly researches treatments for adults, but also does work with kids. And to date, his research has focused on anxiety disorders, especially OCD and OC spectrum disorders, such as Tourette's disorder, trichotillomania, and chronic skin picking. Dr. Twohig works in the areas also of developmental disabilities, substance use, eating disorders, problematic pornography viewing, stigma and prejudice, as well as multicultural issues. He generally researches treatments that are behaviorally speaking, kind of in the tradition of behavioral therapies, including contingency management and exposure-based therapies, but also including more broadly cognitive behavioral therapy and acceptance and commitment therapy, which he will talk with us about in just a moment. Dr. Twohig's work has two immediate aims. One, it's to determine the effectiveness of particular treatment modalities. And two, it's to determine the processes, kind of like the mechanisms of action through which treatments produce their effects. Dr. Twohig completed his bachelor's and master's in science at the University of Wisconsin in Milwaukee, where he specialized in behavior analysis. And he earned his PhD in clinical psychology from my alma mater, the University of Nevada in Reno. Go, Mike. And
And
Mike completed his clinical internship at the University of British Columbia Hospital. He has an impressive scholarly record of publications, books, presentations, grants, and awards. Dr. Twohig works with graduate and undergraduate students with clinical and/or research ambitions. He adheres to the junior colleague style of mentorship. And last, Dr. Twohig co-directs the Utah State University ACT research group with Dr. Michael Levin. Dr. Twohig, we're glad to have you here. Please take it away.
thank you. And I'm assuming you'll yell if I don't have my slides up. I think I have them up.
Yep.
First, thanks to Chris So Quiet and the Duke Research Group and anyone else who's involved in putting this on. This is a wonderful thing, and it's a real honor to be here. You can see the title of my talk. I'm going to talk about four different studies today. So I didn't know who all to put as authors. So you'll see them on the next slide. I'm kind of a unique researcher in a sense, in that I'm actually part of two laboratories. So the one on the top is sort of my audiology research group. And I just the easiest way to get a picture is to steal it off of Facebook, but it's a little bit dated. The student members change, but the two on the right, Deanna and Doris, they were a large part of this misophonia study that we ran. They did all the audiology assessments at the beginning, and actually we have this book on the right, which comes out in weeks. You can like pre-order it, but I don't think you get your hands on it. And then the lab to the lower is probably the one that is sort of my main line of work, which is the research of acceptance and commitment therapy. And you can see some of the students who are all over this. So kind of second from the right is Mercedes, and then all the way on the left is Emily, and I'm in the middle. They were heavily involved in this project, and a lot of the ones whose names you'll see all over this have graduated and are off doing things. So I'm really the figurehead who's speaking for all this work that a lot of people do. The truth is, the people I work with almost have to teach me what happened in some of these things because, um, my team is smarter than me. Now, ACT focuses on this concept of psychological flexibility. And I think it's a cool psychological idea because being psychologically flexible is something that all humans can do across all sorts of situations. So one could say, I'm being psychologically flexible right now, in that I can kind of feel my heart going. I bet if I took my blood pressure, it's higher, my heart rate's higher. But I can do things like just notice those feelings, make space for them, pay attention to the slides on the screen, pay attention to my pacing, look at the few of you who have your cameras on. That being psychologically flexible is really interacting with your thoughts, feelings, and bodily sensations in a open, sort of mindful way so that you can be the kind of person that you want to be in that moment. And if you look at the title of the study here, we wanted to dig into whether people who are struggling with misophonia could demonstrate some of this psychological inflexibility, which would be interesting because then we could help them build psychological flexibility that might help them. Now, this is our measure of psychological inflexibility. So if you look at these questions and you have a high score, what this means is when that individual or you, if you're the person listening, has a misophonic reaction in the sense of like your body gets tight or you feel angry or you have judgmental thoughts, that it's not that you have them, it's that the way that they show up has a lot of power over you. It's kind of akin to if somebody, when they're feeling anxious, they choose not to engage in things. It's like the anxiety has a lot of control. And as someone who's researched acceptance and commitment therapy for, almost 30 years, we've been able to help people who are struggling in this area develop psychological flexibility. And when they do, then those thoughts and feelings and emotions are less in the way. And what's kind of neat about that is if it's an uncontrollable thing, then you can just sort of turn down the volume, turn down the power and the pressure. Now, these look like kind of confusing graphs, and they're really not that bad. So just look at the one, it's on my right. I hope it's on your right too. It says, well, they're the same. It's the bigger of the two. This is a general measure of psychological inflexibility, and we gave it to people who are not diagnosed with misophonia and people who are. And as you can just see from the distribution, a general measure of this that applies to all sorts of people, people with misophonia show that they struggle with their thoughts and feelings more. Not saying they have more, they just get more entangled and kind of have a fighting relationship with them. So then we developed a measure of psychological inflexibility that just pertains to misophonia, and that's the graph on the left. And if you look at that, it's marked, right? Like the way someone with misophonia fights with their thoughts and feelings around sounds is just way, way, way more than another individual. And how that's key is this therapy called acceptance and commitment therapy. We call it ACT because there's already an ACT for a different therapy. Things that end in T. There's lots of acronyms that end in T in the therapy world. What we teach in acceptance and commitment therapy, or ACT, is we teach people how to notice the thoughts that they're having, notice the feelings that they're having, notice any bodily sensations, and how to not get entangled with them, just give them their space, like find a way to carry them, and connect with who you want to be in that moment and practice being that person. And the more you practice this, it sort of becomes second nature. Now, here's the fascinating thing from a research end, and any other researcher here probably knows what I'm talking about, how this part's fascinating. Um, we compared it to a relaxation program, which usually is not a very therapeutic program. And well-controlled, well-trained therapists, like we had all the bells and whistles you should have in a nice trial. We had 60 people, which as a researcher, I'd say is kind of a medium level. I would probably like to see twice as many, but 60 is a lot. This took a boatload of time. It was 10 therapy sessions times 60. It was like 600 hours of therapy, plus assessments at the middle, at the end, and at 2 follow-up points. And here's the gist of it. Zach told me make this really digestible and like people can go home and tell the take-home message. If you want to just look at me, the take-home message here is on this major measure of misophonia, statistically, ACT and relaxation are equivalently effective on this measure with relatively high response rates. So if you look at those numbers on the right, we're talking about 50 to 70% on certain measures are responding to the treatment. So these two interventions are helpful for people with misophonia. We jump to the next slide. This is a different measure of misophonia. And what we find on this measure, again, just broad strokes, is ACT is slightly more effective. So on 2 of the 4 subscales, ACT was more effective. And on this measure, you have a lower response rate. So for the researchers in the group, we do have to figure out what measures we're supposed to use for outcomes. Um, Also had decent effects on well-being. So again, take home, I'm clicking buttons, but they're not working. Take home is these two interventions, ACT and relaxation, are useful in helping people reduce the effects of their misophonia across multiple measures. ACT may be a little bit more effective. And then if you just look at this blue one, people like the treatment. So a score of 21 says it's a neutral treatment, scores higher mean people liked it. And if you're a researcher, this is a pretty interesting outcome in that ACT and relaxation, people sort of equivalently liked it. And that's a solid thing as you're developing interventions that people enjoy what you're doing. Now, the next thing we did is we took all those participants who were in that study and we said, who was this most helpful for? That's what the word moderation means. And each one of these little figures down here is just the publication. And we can help you get to all those. So again, if you look at this and it hurts your eyes, just read the little sentence at the bottom of each one. So you have 4 time points. So pre-treatment, post-treatment, 3-month follow-up, 6-month follow-up. And in all the graphs that I'm going to show you, we took the people at the beginning of treatment and put them into the average, one standard deviation, wait, solid line. Yeah, one standard deviation that's like one notable jump above and then one notable jump below. So we're looking at people, whether they're low, central, or high on these ideas, and how does that affect their responsiveness to treatment? And so here's the first thing. People who were older in our study had better outcomes. And again, all of our participants were adults. So I'm going to name 5 different things that were sort of predictive of who got better. And this would be like a nice thing for discussion later, like why is older more predictive of a good outcome? The next one is those who began experiencing misophonia at an early age had worse outcomes. The next one, wait, actually that one, do I have the same slide in there? Oh, yeah, just 2 different versions of that measurement. So child, when it started for a child, they had worse outcomes than for people who had started later in life. And then maybe this one doesn't surprise anybody, but people with fewer comorbid diagnoses, so if you had misophonia and anxiety or additional depression or substance use or ADHD, people with more diagnoses had worse outcomes. People with fewer diagnoses had better outcomes. And this goes back to the thing that I was talking about earlier, is that this psychological flexibility. So if you think that being psychologically inflexible is predictive of having worse misophonia or is predictive of misophonia, what we found is that people who enter treatment with higher misophonia had better outcomes in therapy. Now, to me, that's like they have more of the thing that we would want to target. So the more you struggle against your thoughts and feelings, the more you fight against them, the more you find them to be terrible, the more you really don't want to be there, then we have more material to work with. So those participants were more responsive to our intervention. So if there's a clinician out there, this data might say, if you're getting clients who are highly psychologically inflexible, there's multiple points of data that would say ACT or something that targets psychological inflexibility would be a logical treatment. Now, this is just a summary of everything I just said, but I feel like I said it pretty clearly. Now, I saw Mercedes. If you want to scroll through the people who are listening, my talented PhD student Mercedes, these 2 last ones I'm going to talk about are work that she did. So this study was actually partially funded by So Quiet, so thank you for that. And what Mercedes did is she compared 60 individuals with misophonia to 60 matched individuals without. And I just think this is interesting because we had an intervention that dealt with stress. And if you look at these 5 styles, anxiety, depression, anger, obsessive compulsive disorder, and stress, Stress is the most related to misophonia of those five things. So comparing the people without misophonia to the people with, there's a bigger difference for the measure of stress than for the other things, which is saying that stress plays kind of a particular role in misophonia. And as a person who has treated a lot of people with misophonia, including on the study, I would agree that when stress is up in the person's life, their misophonia is much worse. Or if a person is living a chronically stressful life, their misophonia is more impactful. And then even on this, what we found was that people who, this is a new study that we have under review that Mercedes is in charge of, that people with higher stress actually responded more poorly in the intervention than to people with lower stress. Which again, when I was talking about psychological flexibility and stress, these are two kind of themes that keep coming up in my talk. These both seem like things that would be worthy of our attention as interventionists and researchers.
You got about 3 minutes, Dr. Twohig.
Hey, I have one slide. I'll
Awesome.
just like putter through it. Um, so if I had my four takeaway points, it's funny when I started in this area, I remember I was at a conference and someone said, from a psychotherapy end, what should we do for misophonia? And my answer was, I wish I had something that I could tell you based on data. And that was 6 years ago. And I'd say now things like uh, CBT, ACT, relaxation, unified protocol, uh, pieces of DBT, and all these are honestly like if they were a family, they're brothers and sisters and cousins. Like they're like kind of a related, logical set of things. And we sort of repeatedly keep finding there's utility to them. Now, we don't know exactly what we should use, but there are things that are helpful now. So I think that is great. And we have a lot of people to thank for helping us get to this place that there are things that are helpful for people with misophonia. I do not believe we're going to hit a cure. I think we're going to learn how to manage and respond to and live with and do better with our misophonia. We are finding some key psychological processes like psychological inflexibility. As everyone keeps doing research, we're going to find characteristics that are predictive of responses. And clinically and research wise, I think stress is going to be one of these processes. So, my final slide is just my lab. So if you want to follow Utah Act, you can see some of the things that we have going on. There's my email address, and huge thanks to everyone who's supported this work and for all the members of my lab who make me look good and let me let me do these presentations based on all the work that they help me do. All right, thank you very much. I can answer a few questions, I think.
Thank you so much, Dr. Twohig. That was awesome. We're always really excited to have a randomized clinical trial in these presentations. And we do have a few questions. So our first one is, can you just clarify if the better outcomes in older adults, was that just with ACT or with ACT and PRT?
Yes, great question. It was across both interventions. So we sometimes when you do those moderation, which is like who does it work better for, you can just lump everybody together and do it across. So that's regardless of intervention.
Thank you. We have someone wondering if your team or if there are other teams here that want to answer in the chat, if you've considered IFS as an option to study its efficacy in treating misophonia, which I believe is internal family systems.
Hmm. Yeah, I have some familiarity with that. I have not studied it. I don't know if other people would be doing it, but no, I haven't got there yet. I know that that is a therapy that is increasingly popular.
Thank you. Back to the older adults question for a second. Which age brackets do you consider as the older portion?
So, um, you're asking me a question. I'd have to like open up the paper next to me and break that down. But the first author is Peterson, and maybe if Mercedes is there, you could drop the reference into the chat, and then you can click on the study and get to it. I'll also say this, if you go to my lab, so utahact.com, every publication we have is there. So if you went there and you could pull that down. But the age we're talking about, everyone's over 18. So it's like, if the average was 36, you're talking that kind of 18 to, 50 zone.
Thank you for clarifying that. Our next question is, does the recent study indicating SSRIs can increase building psychological flexibility make you more interested or hopeful that SSRIs could assist with ACT being more impactful for patients?
Whoa. Kelsey, I see you. Could you post that link? That is fascinating. I don't know that study. Um, yeah, so my apology on not being able to give a good answer to that. That's a really cool study. And for those of you that just, these are antidepressants, that somehow taking an antidepressant could help someone respond to their thoughts and feelings more successfully. I can say in my clinical work, I'm a psychologist, right? I don't prescribe, but I do find sometimes when I have a client and we have worked together for months and we have no movement, that those are the times that I say, like we've been stalled for 10 weeks. I think you should go talk to a prescriber and see if something would be appropriate for you. It can get the client to get moving. So I could see it from that sort of fashion.
Thank you. Our next question. Your team is exploring ACT self-administered. What results are you seeing?
Yeah, thanks a lot for that question. So we do build web-based interventions, and my student Emily Bowers just got a notable grant from the Misophonia Research Fund to take ACT and turn it into a web-based intervention. We have built them for trichotillomania, hoarding, just obviously general ACT, adolescence, and they're all up on our website at utahact.com, and you can use them. And we built one for misophonia, kind of following. We do these like really nice work where we have all these people interact with us, and we get feedback from people with lived experience. And I think we built a really nice program. And actually, Emily has finished data collection, so I think she's ran 100 individuals through the web-based intervention, and we are in the waiting for follow-up phase. So the answer is I don't know, but outside of misophonia, somewhere between a 30 to 50% response rate uh, for these web-based interventions. So, that would be great if this was helpful. We'll tell you soon.
Thank you so much. I think we have time for one more question. Um,
I have a question.
Go ahead.
Is AI playing any role in your research and your work developing um, evidence-based treatments?
That's an interesting question. And literally, we have graduation here, and I was sitting next to my student who does tech research, and we were talking about it. And it it certainly will, and we use it in some of our, web-based intervention work. And what I would want is wrangle it in to give the exact answers I would want it to give. And so we're working on how to do that. So I think it could be helpful in certain ways, but I also want a little control over the type of answers it's getting.
Thank you so much for your
You're welcome.
presentation, Dr. Twohig. And we will see you all in the next session. I have just put